Sciences. So I would like to first invite Dr. Pappa Padmavathi, Professor R.I.U. Trivandrum, for her talk on red flags we should not miss in neurophthalmology. Welcome, Dr. Pappa.
Thank you, Bindu, for giving me this chance. So I'll be dealing with some of the warning signals in the case of neuroophthalmology. Symptom-wise, it is mainly double vision. The patient complains of double vision. You should suspect. And if there is an unexplained visual loss or a headache with defective vision without any ocular cause, or a patient complains of visual field defect like this, a bitemporal defect or visual hallucinations, all these point to a neuroophthalmic case. Diplopia, it should be binocular in a case of neuroophthalmology, and there can be variations with gaze. If it is a nerve palsy, and tilted image indicates a superior oblique palsy. And recent head trauma is important. Diurnal variations are common in myopathies like myasthenia. Associated pain if it is nerve is involved, and systemic diseases like diabetes, hypertension that can produce ischemic nerve palsies. Headache, the location of headache is important if it is on the orbit or in the sinuses, and if there is the diurnal variations and postural variations are seen common with patients with increased ICT. The severity of headache is also important. If it is a constant headache, maybe a tumor. If it's an acute severe headache, it may be a vascular or inflammatory lesion. Defective vision, usually in neuroophthalmic cases, it is bilateral. If it is progressive defective vision, it can be a tumor. If there is associated vomiting, seizure, fever, all these indicate increased ICT. Visual hallucinations are seen in temporal lobe lesions. And on examination, if the patient has a ptosis, a unilateral ptosis with divergent squint, plus or minus an abnormal pupil, it is a third nerve palsy. There is bilateral ptosis, diurnal variations, and fatigue phenomenon. It indicates points to an ocular myasthenia. It is unilateral mild ptosis, small pupil, heterochromia. It's in favor of Horner syndrome. It dilates with apraclonidine or phenylephrine. Amphetamine can be used to differentiate a preganglionic lesion from postganglionic. Visual field defects are an important part of any neuroophthalmic case. It shows different patterns. It respects the vertical midline. It can be bitemporal, binasal, or homonymous hemianopias or quadrant anopias with macula sparing and all. That depends on the site of this lesion. Recent onset squint, usually concomitant, indicates a nerve palsy. Here you can see a left sixth nerve palsy, and this sixth nerve palsy is also a false localizing sign. Nystagmus, there can be downbeat nystagmus, which can be seen in Arnold Chiari malformation or posterior fossa tumors, or there can be CSO nystagmus in case of cellular tumors, or there can be ataxic nystagmus of the abducting eye in a case of internuclear ophthalmoplegia. So all these point to the diagnosis. Pupil, the key player in any neuroophthalmic case. Here you can see the right eye, the direct light reflex is not reacting much. So it's a relative afferent pupillary defect. It's indicative of optic nerve lesions and intracranial space occupying lesions. Anisocoria is one important sign, unequal pupil size. So if you put the patient in the dim light and if it increases, if anisocoria increases means it can be physiological or it can be Horner syndrome or with posterior synechiae. If the anisocoria increases in light means the large pupil is at fault. It can be third nerve palsy or Addis pupil or traumatic mydriasis or even pharmacological mydriasis. Next is the light near dissociation. Here you can see there is no reaction to the light, but the child reacts to the near reflex. So this is usually seen in Addis pupil, Argyll-Robertson pupil, and dorsal midbrain syndromes. Addis pupil, usually the short ciliary nerves are at fault and shows light near dissociation, and there is denervation supersensitivity to 0.1% pilocarpine, and you can see the vermiform movements of the pupil. Argyll-Robertson typically seen in neurosyphilis. It can be seen in diabetic patients, alcoholics, and it shows the light near dissociation. Dorsal midbrain lesions, it is a triad actually. It's an upgaze palsy due to double elevator palsy, convergence retraction nystagmus, and light near dissociation. Here it is mainly due to the dorsal midbrain lesions like pineal gland tumors. Proptosis. If a proptosis is associated with defective vision, it is important. You can see the optic nerve sheath meningioma or if the proptosis is pulsatile, and if it is painful, and if it is associated with defective vision, all these things are important in a neurophthalmic case. A patient presenting like an orbital inflammatory disease, this may be a Tolosa Hunt. You can mistake it for a pseudotumor or a mucormycosis because Tolosa also comes in diabetic patients. Other red flags that we should not miss include optociliary shunt vessels. It is usually seen in optic nerve sheath meningiomas, or a disc edema. It's a bilateral disc edema, points to an increased ICT, or a temporal pallor which indicates any compression of the afferent pathway, the optic nerve and the visual tracts. And sometimes a red day which is not responding to any treatment. When you closely examine, you can see the corkscrewing of the conjunctival vessels, which is usually seen in a case of caroticocavernous fistula. So these are the points I just want to highlight. Thank you for the patient here.
Thank you, Dr. Pappa, for that crisp presentation.